Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 9 of this cardiology series, where today we're going to be discussing the QRS complex as part of our ECG interpretation. So today we're going to be talking about the components of the QRS complex. We're going to be talking about normal morphology and some pathology too. So with all that being said, let's get straight into the video. Okay, so today we're going to be giving particular focus to the QRS complex. Before we get into the bulk of this video, if you haven't already seen my other videos in my ECG interpretation playlist, make sure to check them out before you watch this video. So here's some diagrams what you might be familiar with. Okay, so I have our nice diagram of the heart on the left hand side here. And we can see we're going to basically take this to be lead 2, for example. Remember that lead 2 looks at the inferior surface of the heart along with leads 3 and AVF. Okay, we see we have our negative pole, our positive pole, and we have our QRS complex here. So it's comprised of a Q wave, R wave, and an S wave. They make up the complex, and these represent ventricular depolarization. Okay, and because we have depolarization happening towards positive electrode, which you should exactly know what that means by now. That means we're going to have this positive deflection on the ECG trace. Okay, and ventricular depolarization is much faster than atrial depolarization, hence the sharper appearance to the QRS complex compared to the P wave, which, as you know, represents atrial depolarization. So now let's look at the components, or otherwise known as the waves, which make up the QRS complex. And we're still looking in lead 2, which has an inferior left view of the heart. Okay, so you're probably very familiar with this diagram now. We have our point of view, we have our line of sight, and then we also have our reference point, our negative pole. Okay, so we're looking from that inferior left view. So let's go over the components. So first of all, we have our Q wave, okay, which is a negative deflection, and this represents depolarization of the interventricular septum. Okay, so this region here, in close proximity to our bundle of His, and we can see we have some arrows here because the depolarization happens left to right, and we have the depolarization happening away from the positive electrode. Therefore, this is going to be why it has a negative deflection on the ECG trace. Okay, and it's always important to remember about pathological Q waves. We want to think, has this patient had previous MI? We're going to talk about them later in the video. Let's move on to the R wave, which is depolarization of the left ventricle myocardium. Depolarization is going to happen from right to left. Okay, and we can see we've got depolarization happening towards our positive pole. So therefore, it's going to present as a positive deflection on the ECG trace. And last but not least, we have our S wave, which is a negative deflection following the R wave, and this represents depolarization of the upper lateral ventricular wall via the Purkinje fibers. Remembering they conduct the electrical impulse fastest out of any part of the heart. Okay, represented by these 3 arrows here. We also have some on this side too, and depolarization is going to happen from the left to the right. Okay, and we can see the arrows are going away from our positive pole, hence why we're going to have this negative deflection. And it's not on this diagram, but this point here at the end of the S wave is called the J point. J point is at the start of the ST segment. And then we also have something called the intrinsicoid deflection. You might not be familiar with this term. So this is from the onset of the Q wave, okay, to the peak of the R wave. So if I was to draw a line going from the Q wave up here and then across to the R wave, that's our intrinsicoid deflection. Okay, and if this is delayed, it's greater than about 0.05 seconds. This can be a risk factor for the development of heart failure. So that's just something to be aware of. Okay, so let's talk about some normal morphology of our QRS complex. Okay, so let's talk about the duration first. So we're looking horizontally because we're talking about time. And the normal duration of the QRS complex is that it should be less than 0.1 seconds. Okay, so we can see that it's roughly um, about two small squares wide. Remembering that one small square is 0.04 seconds. Okay, so when we have a narrow complex, this is when the QRS is less than 0.12 seconds. You see this in sinus or supraventricular arrhythmias. Okay, and in these conditions, we have rapid depolarization of the ventricles, which is going to be less time. Okay, so the QRS is going to be less than three small squares wide. And when we have a wide complex, this is when the QRS is greater than 0.12 seconds, the duration that is. And this can be seen in ventricular tachycardia, ventricular ectopics, and also in bundle branch block. And this is when we have prolonged ventricular depolarization. So depolarization of the ventricles is taking longer. Our Q wave should be less than 0.04 seconds. And this is, remember that one small square across is 0.04 seconds, so it should be less than the width of one small square. And in terms of duration, our R wave should be greater than our S wave. So the distance between here should be greater than the distance of our S wave. Okay, so I hope that makes sense so far. And let's now talk about amplitude, otherwise known as height. So our Q wave should be less than 0.2 millivolts. Okay, so remembering that one small square is 0.1 millivolts, we can see that our Q wave is less than that. It's also important to mention that in terms of amplitude, our R waves progressively increase from leads V1 to V5, our precordial, otherwise known as chest leads. And the reason why this is because of the gradual increase in muscle mass from the right to the left ventricle. Okay, because remember that left ventricle has a thicker muscle mass than the right side. So when we're looking on our ECG trace going from leads V1 to V5, we can see that the amplitude or the height of the R wave is going to increase because we've got more muscle mass. Therefore, there's going to be more electrical conduction picked up by the ECG machine. And per R wave progression, so when we don't have an increase in the amplitude of the R waves, this can be suggestive of previous anteroseptal MIs. Other causes can be left ventricular hypertrophy, right ventricular hypertrophy, left bundle branch block, and the list goes on. Even things like dilated cardiomyopathy. It can also be a normal variant in some cases too. And our S wave should progressively decrease from V1 to V5. Okay, so now let's talk about some pathological variants in the Q, R, and S waves. First of all, we have pathological Q waves, which are abnormally wide, greater than 40 milliseconds, and deep, so abnormally deep too, so greater than or equal to 0.2 millivolts. And we can see here we have our pathological Q wave, and these are seen following myocardial infarction. So we can see that they're abnormally deep and they're also abnormally wide. And we get these pathological Q waves because we have a lack a lack of conduction due to the presence of the infarcted myocardial tissue. So the infarcted myocardial tissue isn't going to conduct, hence for the increase in time and depth also. Okay, and typically our pathological Q waves form after patients have an MI. They can also happen in hypertrophic cardiomyopathy, even infiltrative disease such as sarcoidosis or amyloidosis, and sometimes in lead placement errors, particularly when the upper limb leads are placed on the lower limbs, okay, or the upper limb electrodes are placed on the lower limbs. So next we have a dominant R wave. So this is tall, an R wave with a greater amplitude, typically in V1. Okay, and this can be normal in children and young adults. And essentially, this is when we have an increase in the depolarization vector towards our V1, and this can be due to a posterior MI. So when we have infarcted myocardial tissue on the posterior wall of the heart, more of that electrical activity is directed anteriorly, okay, and picked up by V1. Hence why we have our dominant R wave with a greater amplitude. It can also be caused by right ventricular hypertrophy and incorrect lead placement. Okay, and this is typically seen when V1 and V3 are reversed in terms of their position on the chest. Okay, so next of all we have poor R wave progression, which I mentioned on the previous slide. So this can be a normal variant, but it can also be caused by anteroseptal MIs and right heart strain, which can be caused by COPD. You might know this as cor pulmonale. Okay, and this is when we have ventricular depolarization, the ventricular depolarization vector reduced or directed posteriorly. Okay, and depolarization is picked up by the electrodes less. And then we also have persistent S waves, so the presence of S waves in all precordial leads. And this can be typically due to right heart strain. Okay, so I hope that makes sense. Let's move on. Okay, so what we have here, we have an example of an ECG in a patient following a posterior MI. Okay, and what we can see here, so in leads V1, V2, V3, we have ST segment depression. Okay, because our leads V1, V2, V3, they are they're anterior leads. Okay, so if someone has an infarction of the posterior wall of the heart, we're going to have ST depression rather than ST elevation. That's something what you should definitely be aware of. But if we have extra leads, such as V7, V8, and V9, which are posterior chest leads, which go on the back, in them leads, it would present as ST elevation. Okay? And we also have our dominant R wave in V1. So we have it, and it also, we can see that we have an increased amplitude of the R wave. And like I've mentioned previously, this is because posterior wall damage causes electrical activity to be directed towards the anterior leads, and hence the reason for the exaggerated R wave in V1. Okay, so here in this situation, it's important that we can be aware of the findings in V1, V2, and V3. So that was an example of what a posterior MI would look like on an ECG trace. Okay, so what we have here, we have an example of poor R wave progression. If you remember, R wave progression, so the amplitude of the R wave, the height should increase from leads V1 all the way to V5. Okay, so let's just have a look at this. And we know that's because the density of myocardial tissue going from the right side to the left side increases. Okay, so there's going to be more conduction and more electrical activity picked up going from the right to the left side. So let's have a look for ourselves on this ECG trace. So we can see we have our R wave here, our R waves in V2, and they look a lot, they look, they have less amplitude than the R waves in V1. Okay, and then if we look in V2 compared to V3, they're smaller in height yet again. And then in V4 and V5, they have less amplitude yet again. So we can definitely say that this is per R wave progression from V1 to V5. Okay. And some of the things which can cause poor R wave progression, just to reiterate, are left bundle branch block. So block of the left bundle branch on this side, and then anteroseptal MI, and also right heart strain can cause poor R wave progression too. Yeah. So now let's talk about bundle branch blocks. Okay, so an incomplete bundle branch block is where we have a QRS width between 0.1 to 0.12 seconds. An incomplete bundle branch block, the QRS width is greater than 0.12 seconds. Okay, so it's greater than 3 small squares. Let's talk about left bundle branch block first. So what we have something called a dominant S wave in V1. And this is because the right ventricle depolarizes sooner than the left ventricle, and this is, due to the block. And in our lateral leads, we tend to have a broad monophasic R wave, so a deflection in one direction of the R wave in the lateral leads, and this can form an M-shaped complex. Okay. So like I said, the R wave can be notched. It could be M-shaped, but it's typically monophasic, so that it has one direction of deflection. The deflection is in one direction. Okay. You can also have an absence of Q waves in the lateral leads, and this is because the impulse must travel to the right ventricle first, then to the left ventricle via the septal branches. Okay. Other associations with left bundle branch block is left axis deviation and poor R wave progression, which I've mentioned. I want you to be aware of that in the precordial leads, okay, from V1 to V5. So there tends to be poor R wave progression from V1 to V5. Okay, so let's talk about some causes. So this can be due to an MI, cardiomyopathies, myocarditis, heart trauma, so like myocardial contusion, even things such as hyperkalemia, digoxin toxicity. So the list goes on and on. So now let's talk about right bundle branch block. Okay. So what we have this thing called an RSR pattern in V1 to V3, and we have formation of this M-shaped complex. Okay, so sometimes it's called RSR prime too. Okay, and this complex, like in left bundle branch block, can also be monophasic too. So that's something to be aware of. Essentially, what the first R wave represents is septal depolarization. The S represents rapid depolarization of the left ventricle, and then the second R, or R prime, represents slow depolarization of the right ventricle, and that's where we have the location of the bundle branch block. It's in that right bundle branch. We also have wide slurred S waves in lateral leads, and this is due to delayed depolarization of the right ventricle. And then in terms of our causes, we can have cardiac causes, which I've mentioned above, like our cardiomyopathies, our MIs, etc. We also have pulmonary causes, so when we have problems with the lungs, such as COPD, pulmonary hypertension. COPD actually leads to hypoxic vasoconstriction and hence pulmonary hypertension. It's the underlying mechanism. congenital heart disease, particularly pulmonary stenosis, which we can see in tetralogy of Fallot in particular, other things such as atrial septal defects, ventricular septal defects, so the list um, goes on and on. Okay, and we also have something called a bifascicular block, and this is when we have right bundle branch block with left anterior fascicular block or left posterior fascicular block. Okay, so our left bundle branch splits into, it has an anterior fascicle and a posterior fascicle too. Okay, and when we have left anterior fascicular block, this is going to have there's going to be the presence of left axis deviation. When we have left posterior fascicular block, we're going to have some right axis deviation. Okay, so remember our bifascicular block is right bundle branch block with left anterior or left posterior fascicular block. And we can even have something called trifascicular block, which is a bifascicular block plus either a first degree or second degree AV block, which is known as heart block. Okay, so I know that's quite a lot to take on. I'm going to look at some examples and see if we can simplify it even further. Okay. Yeah, so let's look at a diagrammatic representation of left bundle branch block. So first of all, the impulse cannot travel down the left bundle branch. Okay, so for whatever reason, to cardiomyopathy, an anterior MI, we have blockage of this left bundle branch. Okay, so what we have is we have relatively faster depolarization of the right side of the heart, represented by these three arrows here. Okay, and we're going to have our dominant S wave in V1. Okay, on here it's an RS complex, but this is our dominant S wave. But we have some septal branches, so the cardiac conduction system is it's very interconnected. So we still have some septal branches which allow depolarization of the left side of the heart. So from right to left, we can eventually have some depolarization of this left side of the heart, but it is delayed. And the result is typically a wide monophasic R wave, yep, in V6. And if we look at the diagram here, we can see that it is M-shaped, okay? But it can also be monophasic, so it could also just go up like this and curve at the top rather than have this M shape. Okay. I just want to mention something else when we talk about left bundle branch block. I want to talk about a term called appropriate discordance. Okay. So this basically we should have abnormal ventricular depolarization followed by abnormal ventricular repolarization. Okay, and what this means is when we have a left bundle branch block without myocardial infarction, okay, so the ST segment and typically the T wave is going to be in the opposite direction to the majority of the QRS complex, okay, and that's appropriate discordance, okay. So that's when we have a bundle branch block without an MI. We'd have appropriate discordance. So that means that, yeah, so the ST segment and the T wave are going to be in the opposite direction to the majority of the QRS complex. And that's a good sign, that's what we want. But when we have left bundle branch block with an MI, the ST segment is going to be in the same direction as the majority of the QRS complex. So that's known as concordance. So that means that we have left bundle branch block associated with an MI. Okay, so that's something to be aware of. So I'm actually, quite excited to show you this ECG because it's an example about the last part of what I was just talking about in the last slide. So in AVL, okay, so our lateral lead, we have some concordance. Okay, so we can see that we have some ST elevation in the same direction as the majority of the QRS complex. And it's important to mention in this patient's previous ECG, there was some left bundle branch block. Okay, so this is suggestive of a high lateral infarction. Okay, so a high lateral MI. So I hope that makes a bit more sense. Okay, so now let's look at the diagrammatic representation of right bundle branch block. Okay, so we know already that you have this RSR pattern in V1 to V3 with a wide slurred S wave in the lateral leads, so 1 AVL, V5 and V6. Okay, so as you are aware, we have a block in the right bundle branch. Okay, so we hence have this RSR pattern. Okay, so RS, and sometimes it's known as R prime in V1 to V3. So this is V1 in particular. Okay, remember it can also be a monophasic complex too. Okay, so our first R represents septal depolarization. Okay, so that's going to represent septal depolarization. And look in V1, okay, the depolarization is happening towards V1, therefore we're going to have this positive deflection. Wow, look at that. And then we've got some our S wave, which is representing rapid depolarization of the left ventricle, okay? And that's going away from V1, hence we're going to have this negative deflection. And then lastly, we have R prime, okay, and this is we're going to have slow depolarization of the right ventricle because remember we still have some septal branches because the cardiac conduction system, it's all interlinked, still have some septal branches, but the depolarization of the right ventricle is still going to be slower. Okay, so hence we have a final positive deflection with R prime because the depolarization is happening towards the positive electrode, towards V1. Okay, and next in V6, we're going to have a wide slurred S wave in this lead, and this is due to the delayed depolarization of the right ventricle. So alteration in one ventricle's electrical activity can impact the overall electrical activity of the heart and even in the other ventricle. Okay, so I know we have the activity, the electrical activity of the right ventricle in this case, which is altered, but this can even impact the left side, the left ventricle, leading to this wide slurred S wave. But remember, conduction system is all interconnected. Okay. Yeah, so now let's talk about how our QRS complex is going to be affected in ventricular hypertrophy. So first of all, let's talk about left ventricular hypertrophy. Yeah. So what we're going to see on our ECG is something called a left ventricular strain pattern. We're going to see this in V5, V6, in the inferior leads, which you should be well aware. This is leads 2, 3, and AVF. Our strain pattern, we're going to see some ST depression and T wave inversion. Okay, and this is due to delayed repolarization of the left ventricle. Okay, um, we know that we have hypertrophy, so we have an increase in the size of the cardiomyocytes. And the most common cause of left ventricular hypertrophy is hypertension, so high blood pressure, because there's systemically increased afterload. So the left ventricle in particular, undergoes changes in order to try and maintain cardiac output because of the increased afterload. Okay, so I hope that makes sense so far. other features of left ventricular hypertrophy on the ECG, we can have some left axis deviation. We can have a dominant R wave in V5 to V6. Okay, so our lateral, precordial leads, because we have increased conduction from the hypertrophic myocardium on that left-hand side. Okay, we can also have a deep S wave in V1. Other causes of left ventricular hypertrophy, such as aortic stenosis, because we know that aortic valve communicates directly with the left ventricle. Aortic regurgitation, mitral regurgitation, and aortic coarctation. And we can't forget about our hypertrophic cardiomyopathy either. So now let's talk about right ventricular hypertrophy. So we're going to have the opposite. We're going to have a right ventricular strain pattern. So we're going to in V1 to V4 and the inferior leads 2, 3, and AVF. Remember that's our ST depression and our T wave inversion. Okay. Can also have a dominant R wave in V1 because we have an increased thickness of the right ventricle. Okay, so the V1's looking more at the right side of the heart. Okay, and then the main cause is typically pulmonary hypertension. Okay, because we know that blood from the right ventricle is normally ejected via the pulmonary arteries towards the pulmonary capillaries, and that whole pulmonary vascular area. Okay, and then you can occasionally have a deep S wave in V5, occasionally. So other causes of right ventricular hypertrophy are mitral stenosis, pulmonary embolism, anything what's impacting the lungs. Uh, Pulmonary stenosis of the pulmonary valve, which communicates with the right ventricle. That could be seen, like I mentioned earlier, in tetralogy of Fallot. And our cardiomyopathy as well. We can also have something called arrhythmogenic right ventricular cardiomyopathy. We're going to talk more about cardiomyopathies in future videos. Yeah, so this is a pretty classical example of an ECG in a patient with left ventricular hypertrophy. Okay, so first of all, if we look in our lateral leads, so V5, V6, and then 1 as well, and even AVL. But let's look at V5 and V6 so we can see that there's markedly increased left ventricular voltages. So we can see the amplitude of the R waves is very high and it's almost overlapping with the adjacent leads. We can also have some left axis deviation. And the reason why we have some left axis deviation is because if we look at leads 1 and AVF, the R waves are facing away from each other. That's how we know we have some left axis deviation. And then we also in V6 we have our dominant R waves, okay, because of the hypertrophy of that of the cardiomyocytes of the left ventricle. And then if we look in V1 to V3, okay, V1 to V3, we also have some ST elevation, okay. So the reason for this ST elevation isn't fully understood. It's not actually fully understood, but it is present sometimes. And then if we look at leads V5 and V6 again, we have that typical left ventricular strain pattern. Also, let's take V5 for example. We have some ST depression, but then in V6 we have ST depression and also we have some T wave inversion. Okay, so that's that left ventricular strain pattern. So now let's look at an example of an ECG in a patient with right ventricular hypertrophy. Remember that right ventricular hypertrophy could be caused by pulmonary hypertension, where we have increased afterload, which the right ventricle has to overcome to maintain the cardiac output, and this is going to put lots of stress on that right ventricle, leading to hypertrophy. Okay, so first of all, we have some right axis deviation. So again, if we look at leads 1 and AVF, we can see that the R waves are pointing towards each other. So this is going to suggest that there's some right axis deviation. We have a dominant R wave in V1. So let's find V1. Yep, we have our nice dominant R waves in V1 because of the increase in muscle in that right region of the heart. And if we look in V6, we have our dominant S wave. Okay, dominant S waves in V6. Then let's look in V1 to V4. So V1 and V1 in particular, we can see that we've got some ST depression, and in V4 as well, if we look, we've got ST depression, and we also have some T wave inversion too. Okay, so that's everything in this video today about QRS complexes. I hope you found this video really useful. If you did, remember to leave a like, comment, and subscribe. Okay, so thank you very much for taking the time to watch this video. I appreciate any feedback I can get, and make sure you stay tuned for the next video where we're going to be talking about T waves in more detail. Okay, so take care. I hope you're having a nice Christmas, and I'll see you in the next video.